I'm Brad Power. I'm the host with Rick and Brian of the Prostate Cancer Lab. And today we're going to be going through sort of an update on some of the work we're doing every week. There's this approach in Agile they call a sprint. So every week we've got a sprint. We learn something. We've got new issues that we've got on the table we'd like your help with. And this is building on top of the launch event that we had a week ago, where Brian and Rick introduced their backgrounds and their goals and a purpose for this prostate cancer lab. I hope you got the notes from that if you weren't able to join. So just to set this up, I'm going to share my screen and show you we call our poster, which is sort of our process model for what we're up to. And we'll use this today to kind of go around the circle here to update on the different aspects of the prostate cancer lab. And there's some things that are not even on here that Brian pointed out to me. Things like this effort as an initiative and whether we should get grants and that sort of thing. Any questions or comments on this prostate cancer lab poster before I kind of open it up to Rick and Brian to start and go around the wheel here?
Is there a question why cancer is crossed out at MD Anderson? Have they changed their name or something? Or
that's their logo. I think that it's intentionally symbolic. They're trying to
abolish cancer, kind of.
Yeah, they're
okay.
It's the logo. You'd have to ask their logo designers, but that's the real deal. We didn't do that. They did that. And the reason we have MD Anderson on here is because Sumit Subudi, who's on the list there, the clinical reviewers, is there, and we rely on him to sort of keep us apprised of the stuff that's going on there because they're one of the leading academic research centers. Any other questions? Okay. So let's start with attracting patients. We have, I think, 9 or 10 patients that have registered, advanced prostate cancer patients that have registered with us. And Brian's done an outreach to them to see if they would like to participate in a focused meeting, kind of like a focus group, to understand their needs and interests. Brian, do you want to speak to that? You're on mute, Brian.
Yes, it's much more effective when you can hear me. Yes. So I think we were maybe a little bit surprised how many patients actually showed up at our kickoff last week, as well as those that have signed up since, which is encouraging. And when we saw the number of patients, I think there were about 9, we thought it might be worthwhile to understand what their needs are. And in particular, with respect to our mission, which is to improve diagnostics and to increase the speed at which diagnostics are integrated into our clinical care. But we don't want to stop there. We want to understand a little bit more about the challenges that they face and see sort of like what comes from that, what themes emerge, and how that can round out what we're doing here with Prostate Cancer Lab.
Anything else, Brian, on attract patients? I know you were talking to some of Rick Davis's people at ANCAN about getting them involved. Ben's among those people, Ben Nathanson, who's joining us today. And Prostate Cancer Foundation, anything there? Anything on that front?
Not really. So still some more work to do. I think there are a few people from ANCAN that are on here, but no, nothing else in terms of attracting patients.
Okay.
I have a very good connection to Prostate Cancer Foundation. So if it helps anything with, especially with the Chief Scientific Officer, if the team would like, I can invite them for the next meeting or whatever would help here. I'm more than happy to do so.
That's always helpful. Brian has actually had conversations with Chuck Chuck Ryan, Howard
Chuck.
Sewell, and Gina Carruthers. Brian, why don't you just update us on those? But I would ask you to do that to make your just sort of reinforce things so do proceed. But we do have some context there. Brian, how would you characterize it?
Yeah, so I've had various conversations with Howard Sewell over the course of the past year and a half or so. My medical oncologist, Raina McKay, essentially made the introduction to him, and he and I have talked about a number of different things. He's always gracious in taking my call, which is wonderful. And then more recently, I did get connected with Gina Carruthers, who is the CEO and founder, or she's the founder of Uro Today, which is now owned by PCF. Spent about an hour and a half with her, talking a little bit about the prostate cancer lab and other things. And then she actually made an introduction to Chuck Ryan. Chuck is the CEO of the Prostate Cancer Foundation. And again, his time was incredibly gracious, about 90 minutes or so. And we talked about everything from the prostate cancer lab, this initiative, to PCF 3.0, which is the new mission for the Prostate Cancer Foundation, and a variety of different things. So they're engaged. I do plan to reconnect with them in mid-April and give them an update on where we are. And they seem to be open to helping us. And so it's just a great relationship that we're building with PCF.
And
great.
just to underline, our value proposition to them is to give them a patient leg to their heavily research-oriented leg, that they fund a lot of research. Many of the leading prostate cancer researchers they're funding. And then they have their conventions and their get-togethers, conferences where they share that experience. But Brian's really trying to get involved with them and bringing a patient perspective to what they're already doing.
Yeah, so they organize every year a scientific retreat. It's a 3 days that all the top prostate cancer researchers are together. I've attended in the last 6 years or so. This is a fantastic meeting, and they spend 82% of the money they raise on research. So yeah, I'm happy to join you, Brian, or include, because I have a very good relationship with Chuck Ryan and Howard. So
Oh, fantastic. I'm going to take you up on that. So
you're ready.
Yeah, maybe there's a way we can do something in tandem. I would love that.
Deal.
Okay.
And Brian, you went to the 3-day virtual research consortium meeting, whatever it was.
Yeah.
A couple months ago.
Yeah, exactly. So it was in October, and it was 3 weeks. And yeah, I took copious notes and did some work offline regarding themes that I saw, and that was part of my conversation with Chuck Ryan. Was there's a lot of great science that's happening that PCF funds, but I think that there are opportunities for ways of bringing it together and putting the patient in the middle of that. And I walked him through some past experiences that I had in the technology world as a marketing professional, building personalized experiences in e-commerce and other channels. So anyway, we had a very productive conversation. We certainly talked about PCF 3.0, which came out of those 3 weeks. And there's a lot of opportunity. I would also say that Gina Carruthers is very interested in bringing the patient's voice to light in Uro Today, and that is a primary focus. The other thing is that Chuck recognizes that medical oncologists really need to get smarter about how to even translate DNA reports, much less RNA. And here we are, we're about ready to get into proteomics. And so he's really using Uro Today as a way to help educate his constituents, which are medical oncologists. we used some of my DNA reports and our RNA reports, and he said, Brian, you'd be surprised at how many med-oncs wouldn't be able to interpret this information. So he's got some work to do to raise the water level of understanding and interpretation. And maybe there's an opportunity for the patient's voice to be part of that educational process.
And the scientific report, the summarized scientific report of those meetings, usually 3 days, but because of the pandemic, it was spread in a couple of weeks, was just released 2 or 3 weeks ago. So I can send you, Brian, if you don't have it. It is always a very great summary, the state of art, what's happening in the prostate cancer research.
I did get on that. I think Howard, I'm on Howard Sewell's distribution list. So maybe I'm in.
All right. So that was attracting patients and engaging with the large patient advocacy groups in prostate cancer. The next subject area in the next step in the process is all the diagnostic tests. We call it gather data. And this is where Rick Stanton is our leader. In the last week, we added Lucents. They've volunteered to do a blood box biopsy for Brian and run his test. We've also had, we're continuing to have conversations with TGen about being able to use the research use only protocol that they developed and expanding it so that we can use it for clinical use for other patients besides Rick, who managed to get it for himself. So Rick, why don't you update us on the whole area of all these novel tests we're trying to get access to and apply in your cases.
Hi, everyone. Thanks. Yeah, I had a chemo infusion yesterday and I had a rough night last night. So sorry, I'm just getting myself up. By rough night, I just had trouble sleeping. So, darn. And then for me, just as a quick update on a chemo cycle of 3 weeks, I tend to not feel so good right after I get the docetaxel, which I got yesterday. And then after a week, I start to feel better. So at the day before I got my chemo, or I Sunday, I convinced myself that I was feeling Superman, and I got on my mountain bike, and I'm trying to exercise, and I pulled my hamstring on my mountain bike going up the wall, which is pretty challenging even for me 20 years ago, but I determined mind over matter. And so I'm in so much pain for my leg, not anything related to cancer, that I just absolutely couldn't sleep. And it was just like, So anyway, just I'd mention that. And then from a patient perspective, and then I'll dive into the diagnostics. I'm looking forward to getting my PSA reading today. I got the chemo and they do a blood draw, so I'll find out how my control is doing. I started getting that neuropathy in my hands, and I'm a guitarist, so that's a thing that I don't want to see get worse. So I had my chemo lowered by 20% yesterday. So hopefully I still get control. Okay, so my time with chemo is going to be coming to an end. It either just ended yesterday or I'll squeeze a few more weeks. I was on round 6. So the 10 is as far as they hope to go, somewhere between 6 and 10. So this brings up the tests that Brad mentioned. Okay, so what do I go on next? And that's where the tests come in. Otherwise, I am going to be funneled. I'm already at the end of, and I'll say NCCN guidelines, although there's a funneling back, and there's different therapies I haven't seen, but all my care team, which is amazing, led by City of Hope, Tanya Dorff, Raina McKay down at UC San Diego, and Sandy Liu at UCLA, who is running, I'm on an Arcus clinical trial. So what do I do next? So they're all open for, no, sorry, Rick, it's a local wall. I live in between Los Angeles and Santa Barbara, and there's a mountain bike trails. I live 7 miles from the beach, and mountain bike trails to the beach, and it's just like a really steep. I mean, it's so steep that mountain bikers call it the wall. So anyway, actually, not really that many people can go up it without stopping. And I proved that that was a really stupid idea. So what tests? So I've had RNA-seq done on my primary tumor. And I've been pushing for spatial because I'm electrical engineers, and I used to do Earth observing satellites. I know how to segment images and look for tumors, and just was very aware of how much value that would bring to the table beyond bulk RNA-seq. So, but that's really hard to get into right now. So just to elaborate on it, the tests that I'm hoping to have performed that will guide my next treatment, which is, pretty much the reason, that's the first reason for this hackathon, is what is our next treatment, and what is the strategy? Wouldn't it be great if we could get, okay, I'm going to do this treatment, and when that, runs and hits a threshold, I'm going to go on this treatment, and I got a plan. So that's what I felt was lacking when I failed darolutamide, which is a next generation androgen receptor blocker, and I didn't even respond that well. But okay, should I go on a clinical trial? Should I go? There's 1,000 clinical trials sitting around 25 molecular targets. Well, which one? And I was not proactive, and that was probably the worst feeling of my cancer journey, is like, what do I do? And then finding out that none of my doctors really put a lot of credence into any molecular evidence other than my CDK12 mutations. So they did pay attention to my mutations and knew a little bit how to deal with it and use that mutation to guide suggested therapies at the bulk level, but they didn't interpret the RNA-seq, and spatial is still coming on. So those are the diagnostic tests that I'm hoping will inform. I'm lucky enough to be I'm an ex-bioinformatics scientist of sorts. I didn't grow up that usually means that you analyze, you create and optimize DNA sequencing interpretation pipelines. And so I was at the tail end of that. I interpreted not the mutations. That was earlier in the pipeline. We had our team that was focused on, okay, when you sequence, what are the actual mutations that you can clearly identify? And then which of those mutations, we did a germline somatic comparison, subtract the germline. So now these are they're called somatic mutations. They're the mutations that are particular to the cancer that are identified from that subtraction. And so, okay, now here's, this list, typically 1,000 mutations or so. Of that 1,000, which are meaningful. And so we'd run it through our pipeline and compare it against known cancer drivers. And so that is what I've got identified as my basically my one mutation. And I know Brian's got like TP53 and a couple others, but you identify, okay, these are the common mutations that are associated with cancer. And for me, just knowing a CDK12, I have a dual, and that's guiding my treatment at the molecular level and nothing else. So when you get to immunotherapy, you're really need to understand the tumor microenvironment and the immune signaling in that environment. And that's where these tests come in, and the value of spatial. So you can identify neighborhoods of, immune cells and how they're situated next to your tumor cells. If you can answer a basic question, do you have T cells, CD8 in particular, infiltrating your tumor? You have a better chance of responding to immunotherapy. The reason I'm getting so long-winded here, and I'll stop in a second, is we want to identify, do we have, they're called TILs, tumor infiltrating lymphocytes in your tumor, so that they can be activated by the immunotherapy. And if you have a cold tumor, which means you don't have any TILs in your adjacent to your tumor that can perform the kill, it's a lot harder for immunotherapies to work, because immunotherapies unleash that T cell to enable it to kill the tumor. And if you don't have any there, you have to maybe do a prerequisite that'll get the T cells in proximity to the tumor. So that's where the spatial analysis comes in, and will help direct care. So that is
what's the timing on all that? So I think you've laid out the case. You're looking for those tests to give guidance, and because you're at that phase break and you're going to need that information to inform your treatment strategy. When do you think you'll be able to get that from that kind of spatial analysis, proteomics, single cell, that sort of above and beyond testing?
I'm still pushing on it, and there's two vendors that I'm pursuing currently. That's NanoString, the GeoMX platform, and Akoya. Both are exquisite, both are cutting edge, and unfortunately both are research use only. So they're hesitant, these companies are hesitant to perform a test and reveal the results to a patient, because it's a goal of theirs to become mainstream, but they are not currently clinically approved. So TGen is nice. I used to be pals with Nick Shork, or I am pals with Nick Shork, and some of the bioinformatics scientists that I worked with at Human Longevity are now at TGen. They were nice enough to put together a protocol that would allow research use only. But from a patient perspective, this is going very slowly. At City of Hope, they do have the instrumentation. They have my tissue for my primary tumor, and just getting that seems to be, that analysis run seems to be ever elusive. So I'm hoping so your question, when? I'm just trying to get the trigger pulled on, slicing my tumor, my primary tumor, and putting it in the instrument, and that seems to be needing some type of legal.
So
even though I have this protocol.
Let's Brian, why don't you speak to? It seems like Saul Priceman could be we have two breaks to the logjam. One is Nick Shork and TGen providing a protocol that's IRB approved that would allow this research use only testing to be given to a patient. The other is to work in the system with your clinician, let them order the test and let them be the one getting the information. And Saul Priceman could be part of that, and City of Hope. Brian, why don't you speak to that?
Sure. I'll talk about the relationship that we're building with Saul Priceman. And then I think I want to come back a little bit to Akoya, and then talk a little bit about liquid biopsies. And I think some really interesting things that are happening on several different fronts. So I think the way I would characterize the past week for me is really just fortunate in getting ingrained in a number of different things. But starting off with Saul Priceman, he runs the Priceman Lab at the City of Hope. I would probably characterize him as maybe the brains behind the amazing work that City of Hope is doing around CAR T CAR T therapy and CAR NK. In any event, we've developed a wonderful friendship, and he is introducing me to, actually I met somebody a long time ago, it was Peter Kuhn. Peter Kuhn is the CEO of Epic Sciences, but he also has his own lab. And apparently he is doing some cutting edge liquid biopsy work that can get down to, looking at transcriptomics and even proteomics. So that was sort of the tagline for a conversation that we're going to have on Friday. And he sent over a few papers. So we sort of need to get under the hood of this, but if in fact he can get down to, a protein level using liquid biopsy, and there are also potentially some other specimens, not tissue though, it's outside of tissue, that would be potentially a game changer. So we're talking to him, or we will be talking to him.
Peter Kuhn has a lot of research done on a single cell, and that was published as well. He's very famous about doing all these assessments. And I think it's important to connect with him. It was a couple of years ago far ahead on this all omics diagnostics based on single cell.
Yeah, I appreciate that. I think I'm getting to know Saul pretty well. He's pretty well regarded. And I got to tell you, he's been such an incredible champion to support me in this initiative, and Rick and Brad, and also another patient, Bryce Olson. So we're very fortunate to have him in our corner. And so I think where Brad wanted to go is because I'm also being treated at City of Hope. Tanya Dorff just established a relationship with her last week. We could potentially, leverage Saul to potentially, get some of Peter's testing done through the City of Hope channel. So that's something that we're going to be working on, and something that I'm excited about. The other thing, just real quick, through this effort, Lucent's reached out to me to do a liquid biopsy. It's just a cell-free DNA test. I'm going to do that, which is super easy. I'll give blood all day long. It's like no problem there. On the tissue front, I have my primary tumor from 2016. I have my MET tumor from 2020. I know that my MET tumor it's fresh frozen. I'm assuming that my primary is, but I don't know. And so I'm trying to find that out. And I'm also trying to work with my medical oncologist, Raina McKay, to basically get access to that tissue so that I can run the spatial phenotyping that Rick was talking about earlier. I was also fortunate last week, Akoya Biosciences was here in San Diego, and they had a conference. And so I went to go get educated. I think I was the only marketer in the room other than the Akoya Biosciences marketers. So I was a little bit out of my element, but I did learn a lot, and I know enough to be dangerous. Their platform is evolving very, very quickly. They can already test 80 antibodies simultaneously, and I think that they're really almost at 100 antibodies right now. They can cover immune profiling, advanced lymphocytes, myeloid, immune activation, structural, metabolism, stress, death. Anyway, just a number of different categories. So the other thing is that they are installing these machines at UCSD. I don't have a time frame in terms of when they will be available. They're currently just getting them engineered and set up at UCSD, which is great because obviously that's going to fit into the protocols, where my primary medical oncologist is. So I will be leveraging that. And then the other thing I would say is there was a doctor from Cedars-Sinai. His name was Zhaojiang Chu, and he is building organoids, not using cancerous tissue, but healthy tissue to build organoids. And he's using Akoya's spatial phenotyping to better understand how these organoids actually work. So, it's really interesting because we know that tissue is the scarce resource in this diagnostic, adventure that we're going on. And if there's a way to use organoids or, blood, as what we're going down the path with Peter Kuhn, those could be really game changers in terms of our ability to have much more accessible and much more powerful diagnostics, which is what we're trying to get into the clinical conversation, rather than just conversations about various treatments. I want to know what's happening with my cancer. And so these are really exciting developments. One other thing about Akoya, because I recognize that tissue is the limiting factor, I spoke to Dr. Oliver Braubach, who is the head of applications at Akoya, about whether or not they've ever used blood to put them through their assays. And he did say that they have done whole blood, PBMC, peripheral blood, mononuclear cells. Said it's a little tricky because it smears, but this is something that they are also looking at. The smearing thing for me, is just a layman. I was just like, freeze it. Can you do something to figure that out? But anyway, that's obviously too obvious of an answer. But I'm just sharing this because, as you all know, the pace of development is so fast, and they are a great case in point for that.
Glenn, you have a question?
What is the possibility of fresh tissue, fresh unadulterated tissue?
Yeah,
You mentioned
biopsies from your existing Mets, Brian.
Yeah. So let's talk about that. So I was just talking to Raina about that, just an email chat. She's a little hesitant. So I have, Glenn, 3 Met tumors currently in my peritoneum. The largest was about, I think, 2 centimeters. I also have caking as well. So, they're not going to do surgery because I've just got microscopic, right? So,
no primary.
My primary's gone, so my prostate is gone. So, but we still have that available. I just need to find out the form factor, if it's FFPE or if it's fresh frozen.
So if you had the ability to get, a new biopsy and enough tissue, you mentioned organoids, something I'm very interested in. You're talking about with the healthy tissue, why not, grow the microscopic, Brian's prostate organoid with the actual tumor tissue from the Met site through S-engine Harris test. Have you looked at that?
Yeah. Yes, I spoke to Carla about 2 or 3 weeks ago.
That's Carla Grandori, for those who don't know.
Yeah, Carla Grandori. So yes, I spoke to her, and so that is a possibility. The challenge that I have right now is that, I think good news, bad news, is that I'm responding to abiraterone. And so my tumors are likely shrinking. And so there's a question of, whether or not it makes sense to go in and do a biopsy.
Yeah.
So I would love, any opinion on that. So Rana McKay was kind of open to it, but didn't see, just she typically would do a biopsy on a tumor that is in a growth pattern,
Yeah.
as opposed to.
And then you would need a washout period depending on the agents that you're on before you could, they would want to handle that tissue.
Yeah,
Yeah.
agree. But yes, so with SNGen and their organoid, they would need fresh. They need live.
Overnight.
They need
Overnight.
live, fresh, frozen. Yeah, which is different than fresh frozen. So I'm learning a little bit more about pathology than I ever thought. But so that's a possibility. It just means that I need to determine whether or not I can actually get the biopsy.
And just two things. Heather Messerly dropped off. She's with Certus, and we learned in one of our previous hackathons that the quality of the tissue is really important. That, like, when they try to create mouse models, they're only successful about 40% of the time. So it's very important, not only that there's tissue of adequate quantity, but quality and all that handling. It's pretty dicey and sometimes doesn't work even so.
It is. I just went through this process with SNGen with a family member a few weeks ago, and at the primary, and there was enough tissue, but for whatever reason, it just wouldn't grow, and we're still hopeful that it will, but we're already a few weeks into the process.
I want to cue John Powers. John, if you don't mind my putting you on the spot. John is also in the San Diego area. Also, he's the CEO of a company, SimpleSeq, that also is involved in this area, doing multiple tests and working with tissue. John, do you have any comments on the previous conversation? Again, I hope you don't mind my putting you on the spot. And if you're there, you're on mute if you're speaking. I guess he may not, he may have walked away. All right, so anyway, that's for a future conversation. SimpleSeq is pretty interesting as a startup in the area that we should also talk about in this area. In the interest,
I had a comment
Okay.
because actually TGen is trying to organize, via TGen, I haven't brought this up. They're trying to organize an organoid study, and Glenn, I have multiple metastases at the nodal level, and UC San Diego, Rana McKay's pathology team said that they could biopsy it, but when I started on a clinical trial run out of UCLA, they said it was too hard to get to and too small, and they can't. So I had directly differing opinions. Now I'm coming off of chemotherapy, and Dr. Dorf recommended bispecific PD-1, CTLA-4, and olaparib, if I'm saying that right, which has been approved to CDK12, but then after that approval is a little less compelling of a single agent drug. But she said, yeah, that's true, but in tandem with the CTLA-4 Zencor's clinical trial, that would be her recommendation. The reason I'm giving you this background is a prerequisite to get on that clinical trial is sequencing a metastases. So they've got to, I have UC San Diego saying we can get it, the pathology team, UCLA saying we can't. And so now Dr. Dorf's team of pathologists is going to look at can they get a biopsy, which would qualify me for my next treatment as recommended by Tanya Dorf. So I'm hopeful as part of that biopsy is the organoid study. As part of this precious biopsy from a nodal, which is not that large, 1/2 centimeter by 1 centimeter roughly, could we get enough tissue to sequence, to do an IHC? And by sequencing, I mean DNA and RNA-seq at the bulk level, Do we have enough to do spatial analysis for nanostring and Akoya platforms and do organoid studies? So there's I need to, I don't think organoids studies need much tissue, but I don't know. So that's
Yeah,
my understanding.
I don't know what their minimal specifications are as far as volume of tissue and that sort of thing.
Yeah,
Yeah.
Rick, let me move on. I'm just sensitive. I want to get around the wheel and
yes,
and open
thanks.
it
Oh
up.
gosh. Thanks.
Yeah. So, and I just, for those who don't know, Glenn is a hero of mine because he's an integrative expert, integrative medicine expert, and wrote the book N of One about his own journey through kind of a what do they call it, miraculous responders in getting his CLL under control without typical medicines. So I also want to introduce Laura. If you're not eating your lunch, as we move on to the next section, we want to talk about analysis and treatment options. And you work at Reboot RX, and maybe you could tell us about Reboot RX and whether I don't think you're on our poster. You probably should be. Can you introduce Reboot RX and tell us about what your contribution could be to the cases? Oh, and she may have stepped away as well. No, there she comes.
I'm
All
here.
right.
I'm here.
There we are. Okay, good.
I have to multitask at the same time, though.
Right, sure.
Yeah, I am not quite sure how we can help. So that's why I'm, trying to listen in and stay as engaged as I can in the meantime, but happy to tell you a bit about what we do at Reboot RX. So we are a nonprofit startup, and our goal is to get affordable treatments to patients faster using repurposed generic drugs. And we're developing AI technology to be able to sift through a lot of data on generic drugs to be able to systematically prioritize repurposing opportunities. And in collaboration with Brian, who really inspired our first deep dive, we selected prostate cancer for our first cancer type that we would focus on. And we've been working on that together since mid of last year and engaged with a few of you here. So it's good to see you. So what we did with that project was we sifted through all of the PubMed studies that mention any of the 1,000 non-cancer generic drugs and prostate cancer, which is around almost 17,000 publications. And we ran them through our technology to be able to identify the relevant studies, which what we mean by that are studies where non-cancer generic drugs have been tested for the treatment of prostate cancer with clinically relevant outcomes that were reported. And so we've identified more than 80 non-cancer generics that have been tested in a clinical setting for prostate cancer, and then developed a scoring algorithm to be able to basically integrate all of the data across these clinical studies and rank the generic drugs with the most promise. So we've identified some promising candidates and are in the process of moving them forward. But our goal is not necessarily to promote any off-label use of the drugs right now. Our goal is to gather the definitive evidence so that we can be confident that they're both safe and effective for treating their new indications, in this case, prostate cancer. So while many of these have been tested in clinical trials, including randomized controlled clinical trials like phase 2 trials, for the most part, there isn't that definitive phase 3 evidence yet. Happy to go into more detail, but hopefully that gives you a sense of what we're working on.
Are you working on small molecules largely?
We are looking across all drugs that are FDA or drug products that are FDA approved that have gone off patent and are not approved for or commonly used to treat any cancer type and are available as generics. So anything that falls in that category.
So that modality would typically be small molecules is my question.
Yep, some of them, yep. But
Is
Do
there
you use
any
molecular evidence? Sorry, I used to do high throughput screening at Amgen and counter screening, and I ran those platforms so a little bit of a question. Is your AI matching anything specific to a patient to your small molecules?
Do you mean any molecular characterization?
Yeah, like a mutation, an RNA-seq, anything that would be not population driven, like we know all cancer, prostate cancers patients tend to be this. And that is how my therapy is being determined now. But I think part of our testing is to know that, well, Brian's cancer is different from my cancer. So your platform might pick out a different therapy. Is that true? Do you use anything that's different between Brian and I?
At this point, where we started was just analyzing the published literature. And in most cases, there aren't specific subpopulations that are molecularly driven in which the drugs have already been studied. So that's where we're gathering the data currently. We're also adding on additional data types at this point, but it's still early days. But the goal is to get to that point.
I would think on top of your AI, so you have these 1,000 drugs, or you have many drugs, 17,000. I mean, a large virtual pool of, I'll say, small molecule structures that you're trying to determine might be a best fit from using your AI platform. And so my question is, I mean, I would think what I would want to do is, we've talked about organoids. So the idea is to grow up a colony of prostate cancer organoid from some small seed cell. Okay, we got the seed cell, we got the tumor fresh. Now we're growing a colony of a tumor colony, in a petri dish. And then your platform will come up with, well, I think there's these prioritized list from our prediction of these 7 small molecules that will, pipette into different clones of this organoid and see what arrests the cancer. Is that your vision? Like, is that how you would use your platform?
It could be used in that way in the future. We're not at that point right now. We just got started.
Are you planning, or do you have any access to data sources? Because these drugs probably were used in the clinical setting. So any electronic health records to look into that, whether they were used, and that would complement the phase 2 studies or only the published evidence, and to collect and structure all the available evidence. I know even FDA is open with generic drugs that are used off-label to add new indications based on real-world patient data.
Yes, that's what we're doing now. Yep. Early days still, but yes.
I saw, just quickly, Laura, I saw Syed, I think is his name, from Rutgers, on the Shirley Pepke hackathon, which I'm helping on, where he did a similar analysis of I don't know, again, existing drugs. Are you acquainted with his work?
The name sounds familiar, but if you could send me that paper, that'd be great.
Yeah, I will. I'll send you his contact information and also the analysis that he did. I probably have that somewhere as well.
Thanks.
Okay, again, in the interest of time, let's move on to the last section, which is the clinical area. And Brian, I think you have some updates on clinicians you've spoken to. You mentioned Peter Kuhn, Saul Priceman. I think you spoke with Michael Morris at Memorial Sloan Kettering. Any kind of updates on the state of engaging more clinicians? Oh, and you and I spoke to Mario Galusic this past week. So yeah.
Yeah, so I think we covered, Peter and Saul. I did speak to Michael Morris last week about this endeavor. He is engaged. He wants to stay engaged. Obviously, he's got a big job at Memorial Sloan Kettering. He encouraged us to think about pursuing this from potentially a grant perspective, where we could use the grant structure to engage more clinicians in a way that is familiar with them. So for example, my Dr. Raina McKay is, going, as well as Tanya Dorf, are going after an initiative. I think I mentioned it last week, called Promise. I think it's a PCF grant. So that's kind of the way that they work. And he suggested that we think about, how we would want to approach that. So I haven't taken any steps since then on that advice, but he's certainly somebody who we can speak to about this, and he'd be happy to help us if that's the direction that we want to go.
Okay, so and just a general request, we're looking for many more clinicians to participate. If you know anyone, I'm looking at you, Shoshana, in particular, that we might invite to review things. So we're working with them individually to make it as easy as possible. We know they're all frightfully busy, and we're having conversations with how they can work with us. Maybe just a quick email occasionally to give us some guidance. So try to make it as easy as possible, but engage as many clinicians as possible. So that pretty much has us wrapping, going around the circle. There are a couple questions that Rick has put in the chat. I'd like to ask Rick Davis to share those. We can cover them live.
So, we've gotten 55 minutes into this, and I feel like we're just chasing our tails here. I have to say, this is very rewarding for the scientists. But I come to this from the perspective of what can we do for the patients right away? Notwithstanding, they need to be thinking down the road, but that point was made last week. There was a huge sea change, if you like, in terms of approvals last week with Pluvicto. And I know that if I was Brian or Rick, what I would be doing right now, rather than looking at all these exotic strategies, is to get my name onto a wait list as soon as the lutetium 177 PSMA 617, which has now been commercially retitled Pluvicto. And don't ask me to give you the generic name. I'd have to get it up on the screen to do that. Vipapitide something or other, I don't know. Here's what we know. Both of you guys are PSMA avid. We know that from your scans. We also know that this treatment is very effective. Was it effective for Bryce? Not as much as it could have been, but then he went with actinium, he went with a lower dose. And if I were Bryce right now, I'd be doing the same thing. We had a guy who didn't do well on 3 high-level doses of lutetium, and they put him on to 6 doses. They switched him to a different trial, and he responded with the lower dose 6 cycles, which is what's been approved. So I would love to see both of you guys on that. We can come back to this and we can continue doing this, but we need to do something for you now. Now, where can you get this drug? We're not sure, because all the managed access trials have been closed. That was a condition of the FDA approval. So we're not really sure who has the hospital approvals in place to deliver this on a market basis. We think that UCLA does, which would be appropriate to both you guys. That would be the closest, we think. We don't know. Calais will, if you get hold of Calais, he's going to tell you if he can deliver it market. From a price standpoint, Advanced Accelerator Applications has made arrangements until Medicare covered to subsidize. And in your cases, since you may not have Medicare, I'm not sure if you have a SSDI or not, and if you've been on it long enough, that would be applicable to both of you. So AAA is well aware that this doesn't cover everybody, and their Patient Connect program has a telephone number in there. And if you don't get anywhere, call us. and we'll put the strong arm on AAA and say, you're not doing enough for guys, for younger guys who need it. But I cannot urge you enough to refocus your efforts over the next week to get yourself into a program which will deliver lutetium 177 PSMA 617 to you.
And is that
So-
Pluvicto? Is that what?
Pluvicto is the name. So the website, I'll put it in. They actually have a website that they've set up, pluvicto.com. And that's, like I say, that's the commercial name. I mean, that's what everybody's calling it now because it's easier to say than anything else.
I was told yesterday by my oncologist that it is available in Seattle at SCCA as well.
Is it available now on a market basis? That's helpful. That's very helpful.
I believe
If-
so. I mean, you have to be castration resistant, which I am not, but yeah, it's available.
Okay.
They said since September they'd had it available.
Yeah, but that's not the same.
What do you mean?
See,
Caroline?
here's the issue. They've had it available in managed access in some of these sites.
In trials?
So we know several sites where it's been available in managed access trials. The problem is that those hospitals may not have approved to deliver it to outside of the trial. So Hopkins, for example, last week gave Herb Geller, one of our board members, he got his first application. He just snuck in under the wire, and so they'll continue. But Hopkins is not going to deliver it to the public for several months because they don't have the approvals in place. So there's a difference between being able to deliver it right now, which several hospitals we know can do, and being able to deliver it to the public as an FDA approved drug. And that's where we don't know, not even AAA is aware. They said to me, they think that UCLA, Chicago, University of Chicago, Mount Sinai, and Tulane, Sartor. So again, you guys have a relationship with Oliver Sartor. Call him up and say, are you delivering on a market basis? If you are, get your name on there. So you have to fly to Tulane. It's a lot closer than Australia. And so you have to fly to New Orleans once every 6 weeks, But that's what we don't know yet. We know it can be delivered, and we know it's being delivered in managed access. We just don't know which hospitals are approved to deliver it to the public yet. And that's their own internal approval.
So Rick, do you know what the best outcomes have been